So last class we discussed about acute nephritic syndromes, and this class is going to be about basement membrane syndromes. But before we actually go into basement membrane syndromes, I had promised you last time that we'll discuss two more diseases in acute nephritic syndrome. So that's what I'm going to start this session with. Okay. So we're going to discuss a little bit about IgA nephropathy and C3 glomerulopathy before going to basement membrane syndromes. And apologies for my voice. I'm running a fever and a cold. But anyway, let's get on with the class. Next. Can we go to the next slide, please? Yeah. So IgA nephropathy. Okay. So this is also called Berger's disease. And the photo of the doctor on the screen is Jean Berger. So he described this disease along with his colleagues, mainly Nicole Hingley. And I've italicized that name because you're going to hear that name one more time in today's session. And they described this disease with the help of immunofluorescence and electron microscopy fairly recently in 1968. So that's Jean Berger. And the other image on your screen is the immunofluorescence image of IgA nephropathy. If you remember in the last class, I told you about how the IgA immunoglobulin deposits are there in the mesangium. Okay, so you can see in the immunofluorescence also that the green color has lit up in the mesangium and not in the capillary tuft. So that's what you have to pick up in this image. The brightest green is actually not there on the basement membrane. It's not there on the capillary tuft. It's capillary wall. It's actually in the mesangium. So IgA nephropathy is a sporadic disease, which means there's less of heredity involved, and it is one of the most common primary glomerulonephritis worldwide. But still, there are some pockets which are more affected by IgA nephropathy, specifically the Asia Pacific regions and southern part of Europe, where the prevalence is fairly high. And there is also a closely related disorder to IgA nephropathy, which is Henoch-Schonlein Purpura. Now, Henoch-Schonlein Purpura is generally seen in younger individuals, and you have prominent systemic symptoms in Henoch-Schonlein Purpura. Namely, you have your arthralgias, you have constitutional symptoms, you have colicky, abdominal pain, and also skin rash, a very peculiar skin rash that generally affects the lower limbs and the buttocks. Okay, so there is a palpable purpura. That's where the name comes from. So you have a triad of palpable purpura, bone pains, and colicky abdomen pain. That's your Henoch-Schonlein Purpura. And IgA deposits are also seen in other diseases. Whether or not they are pathogenetically important is another thing. Usually, they do not set up inflammation in the kidney in those scenarios. For example, a chronic liver disease patient can have IgA deposits. Inflammatory bowel disease can have IgA deposits in his kidney. Celiac sprue, that is the malabsorption syndrome, your ankylosing spondylitis. These are few prominent examples where you can have something called a secondary IgA nephropathy. Fine, but it does not really cause inflammation inside the kidney. So these are the points that you have to take from this slide. Next slide. So a very similar sounding disease, because you're all medicine postgraduates. I wanted to bring this point to you. Long ago, much before 1968, 1908 to be exact. So in the Mount Sinai Hospital, there was a surgeon called Leo Berger, and he described a disease called thromboangiitis obliterans. Okay, I've just put it just to uh, impress upon you the similar sounding names of both the diseases. Okay, so you have something called Berger's disease, which is IgA nephropathy, and a similar spelling, just the a U comes extra. The Berger's disease, which is thromboangiitis obliterans. They are two different things, and as you know, thromboangiitis obliterans is inflammatory vasculitis where you will have the reduced blood supply to your extremities, and you can have your dry gangrenes. It's fairly common in your active smokers. So that's something that you know. Similar sounding names. That's what I wanted to point out. Next slide, please. So this is a map which shows you the global prevalence of IgA. So what I want you to note is the darker the blue, the greater the prevalence. So you can see that China, it's a darker blue, and the southern part of Asia, southern Asia and Southeast Asia, when you look at Japan, they are the darkest blue. So that's why I told the Asia Pacific carries the greater burden of IgA nephropathy. In this diagram, if you look at it, India doesn't have much of a color, but let me tell you, it's a very, very common disease that we see in clinical practice. It is perhaps not reflected in this diagram because of the lack of scientific research that goes on in our country, definitely. And we are not able to reflect it to the world, but definitely IgA nephropathy is fairly common even in our country, and is slightly more virulent than the IgA nephropathy that is seen in the Western population. Next slide. So when you talk about the pathogenesis of IgA nephropathy, what actually happens is there is a defect in the galactosylation of the IgA1 molecule. Okay, so IgA has two classes, two subclasses, IgA1 and IgA2. Specifically in the IgA1 immunoglobulin, in the hinge, there is a deficiency of galactose. Okay, now because of this, what happens is certain cryptic epitopes are now open to our immune system, and therefore it incites the formation of antibodies against the galactose deficient polymeric IgA1 molecule. And this antigen antibody complex is going to deposit in your kidney and set up the inflammation. Now, there usually is a second hit which affects the manifestation of disease. So, somebody has a galactose deficient IgA1, perhaps right from birth, but there takes a second hit for it to actually manifest as a disease. And this is one reason. So, what are those second hits? They can be infections or they can be added alternate complement pathway defects. Now, infection is the reason why IgA nephropathy is a very, very common cause of macroscopic hematuria or synpharyngitic hematuria, where during an upper respiratory tract infection, your patient is usually going to have red urine. Okay, they're going to be passing red urine. If you remember from the last class, we had discussed about the different presentations of glomerular disease, and IgA nephropathy can present as whatever depending on the screening strategy that we are using. For example, say Japan. Okay, Japan has a lot of IgA nephropathy, so they screen almost everybody, all the school children, whether they have any microscopic hematuria. So IgA nephropathy in a country like Japan is usually presented as an asymptomatic urinary abnormality. So because they're going to screen everybody who's even normal, and they're going to pick up RBCs in their urine. So asymptomatic is the presentation, is the most common presentation perhaps in a country with uh, effective screening strategies like Japan. Whereas when we take a country like India, what we see commonly in clinical practice is the last one, chronic glomerulonephritis. Your patient has had a silent burning disease, and then he presents to you fairly late with an elevated creatinine, say 2 or 3 or 4, after he started showing up the symptoms of kidney failure. So chronic glomerulonephritis is perhaps one of the more common presentations of IgA nephropathy that we see in our country. Obviously, there are a fair share of cases which present to you with macroscopic hematuria, and they do well because they're fairly diagnosed early. And you also have a subset of patients who present with nephritic syndrome. That's why we are discussing it under nephritic syndrome. The two rare presentations of IgA1 are nephrotic syndrome and rapidly progressive glomerulonephritis. You're very, very unlikely to see this kind of presentation with IgA nephropathy. Now, I've put in the inset a screenshot from Harrison's textbook, where I want to point out a couple of lines. Okay, so let's just read. IgA nephropathy is a benign disease. Let's read together. Is a benign disease for the majority of patients, and 5 to 30% of patients may go into complete remission, with others having hematuria but well preserved renal function. In the minority of patients who have progressive disease, the progression is slow, with renal failure seen in only 25 to 30% of patients over 20 to 25 years. So, this line from Harrison kind of gives you the impression that IgA nephropathy is not a serious disease, but no. The next line is very important. This risk, that's what I've underlined in red. This risk varies considerably among populations. And in our population, the Asian population, the Indian population, the Chinese population, Japanese population, IgA nephropathy is not a benign disease. It is a fairly serious disease in which the progression to end stage renal failure is not so slow as mentioned in Harrison. It is pretty fast. Okay, it is pretty fast. So actually, your concentration has to be on that line. That's why I've highlighted that for you. Please do not consider IgA nephropathy as a not so serious disease because the lines before give you that kind of an impression. So it's very important for us to seek the diagnosis of IgA nephropathy and give the benefit of immunosuppression to our patient.